Acute cholecystitis, or this inflammation of the gallbladder, usually comes about because of a gallstone being lodged in the cystic duct. The cystic duct is the one that leaves the gallbladder and connects to the common bile duct. So let's say this person's gallbladder's got a few gallstones in it, and they go to eat a hamburger. The small intestine secretes cholecystokinin, sometimes shortened to CCK, into the blood where it makes its way to the gallbladder, and signals it to squeeze out some bile to give it a hand with digestion of that hamburger. The gallbladder contracts and one of these stones gets lodged right in the cystic duct, which blocks the bile flow. Now what? Well, this person will probably start experiencing some pain, specifically mid-epigastric pain, which happens because the gallbladder is trying to squeeze on a blocked duct. And just like if you squeezed a partly filled balloon with the end blocked off, it physically stretches out and irritates the nerves in the gallbladder and the duct. This can also lead to nausea and vomiting, which can last for long periods of time. And as that gallbladder squeezes more and more, the stone might get even more stuck. And at this point, the bile, being stuck in the same place, or in this state of stasis, becomes a kind of chemical irritant, and causes the mucosa in the walls to start secreting mucus and inflammatory enzymes, which results in some inflammation, distension, and pressure buildup. At this point, there might also start to be some bacterial growth, most commonly E. coli, which is all over the gut, but also Enterococci, Bacteroides fragilis, and Clostridium, which can also be found there. As it sort of starts to balloon up, the pain might start to shift to the right upper quadrant, and it'll be this kind of dull, achy pain that can even radiate up to the right scapula and the shoulders. After a while, bacteria starts invading into the gallbladder wall and eventually through the wall, causing peritonitis, inflammation of the peritoneum, which can cause what's called rebound tenderness, where pain is brought on when pressure is actually taken off the belly rather than when it's applied. Here's another physical exam trick though. We know that while a patient takes in a deep breath, the diaphragm pushes down on the gallbladder. You can apply pressure on the abdomen to keep the abdominal contents from sliding downward. With the abdominal contents roughly pinned in place, you can ask the patient to take a deep breath. And if the diaphragm pushes down on their gallbladder, which remember is pinned in place, this will start to cause pain, forcing the patient to stop breathing in further. And that'd be a positive Murphy's sign, which can help with the diagnosis. Finally, since the bacteria started invading the mucosa and the tissue, the patient's immune system kicks in, ramping up the neutrophils in the blood and leading to neutrophilic leukocytosis, and likely also causing a fever. At this point, one of two things can happen. First, the stone could fall out of the cystic duct, which is great, and then the symptoms and cholecystitis eventually subside. This actually happens in the majority of cases. The other thing that could happen, though, is that the stone doesn't fall out. And if that's the case, pressure can keep building up, eventually so much so that it starts pushing down on the blood vessels supplying the gallbladder with blood, which means blood can't get to the gallbladder and the tissue starts to get ischemic, leading to gangrenous cell death, which is cell death due to not having enough of a blood supply. As the gallbladder walls weaken, it might eventually perforate or rupture. This causes sharp pain and, if left untreated, could allow the bacteria to get into the blood supply and cause sepsis. If it's allowed to get this far, it's possible the patient needs a cholecystectomy, or a removal of the gallbladder. For some patients, though, if the stone gets lodged further down in the common bile duct instead of the cystic ducts, it can start to block the flow of bile from the liver. Because remember that the liver cells help produce bile, right? If those liver cells keep producing bile, but none of it can go anywhere because of this blockage, bile can start to back up into the liver, which increases pressure in the bile ducts and causes the bile to eventually force its way through the tight junctions between the cells lining the bile ducts and make its way into the bloodstream, causing this increase in serum conjugated bilirubin, which is a component of bile, which eventually leads to jaundice or yellowed skin. An important marker that might also be found in someone's blood that has cholecystitis is alkaline phosphatase, or ALP. This is an enzyme found in high amounts in the liver and the bile ducts. So when bile backs up and pressure in the ducts increases, these cells lining the ducts can be damaged and die. And when they die, they can release their ALP, which can then get into the blood. One way to help diagnose cholecystitis is by ultrasound, which can detect stones as well as sludge and mucus buildup and get an idea of how thick the gallbladder wall is. If the stone's lodged in the common bile duct, though, it's a lot more difficult to pinpoint. If that's the case and ultrasound hasn't really shown us anything, a cholecystigraphy or HIDA scan might be done, where this radioactive tracer is attached to HIDA, or hepatic aminodiacetic acid, and then injected into the patient. The marked HIDA is taken up by hepatocytes and excreted into the bile, which then drains down the hepatic ducts. If there's no blockage in the common bile duct, the tracer will make its way through the ducts and into the gallbladder and small bowel, which you'll be able to see. If you can't see any of those, then there's likely a blockage. Like in this HIDA scan, the dark spot indicates an obstructed duct.